Good morning, good evening, good afternoon, wherever you are. Welcome to another Intensive Care Hotline and intensivecareathome.com live stream where I will answer your questions. Now, thank you so much for joining the show live, but I also want to welcome anyone that's watching the live stream in the recording. I do these YouTube live streams once a week. And hi, Modema, nice to see you again. So I do these YouTube live streams every week, usually on a Sunday morning, 10:30 a.m. Sydney, Melbourne time, which is currently 8:30, I believe, 8:30 p.m. Eastern Standard Time, which is 5:30 p.m. Pacific Time, and it is currently in the middle of the night in the UK. It's 1:30 a.m. in the UK. Anyway, let's not get sidetracked. Before I go into today's topic, you may wonder, what makes me qualified to talk about today's topic and about topics in intensive care in general and intensive care at home in general. So I'm a critical care nurse by background. I have worked in intensive care / critical care / ICU for over 20 years in 3 different countries. I have worked as a nurse unit manager for over 5 years in intensive care. I have been consulting and advocating for families in intensive care all over the world for the last 10 years as part of my intensivecarehotline.com. I'm also the founder and managing director of intensivecarehome.com, where we provide intensive care at home nursing services for long-term intensive care patients, predominantly focused on ventilation and tracheostomy, but also non-invasive ventilation such as BiPAP, CPAP, seizure management, home TPN, and enteral nutrition, of course. We are currently operating all over Australia with intensive care at home, but we're also in the process of helping families in the US with intensivecareathome.com as well. Now, some housekeeping issues. If you want to ask any questions, please type them into the chat pad and I will get to them. Alternatively, I will also open up the phone lines after I've gone through some questions today. I will open up the phone lines and you can dial in live on the show. But for now, just type your questions into the chat pad and I will get to them in due course. Now, let's get on to today's topic and to today's questions. Normally what I do on these calls, on the YouTube lives, I read out questions that we have from readers or from clients and highlight some case studies so you can, get the most value out of these calls. So let me just go back to the emails that I had. And here is an email from Diane this week, and I'll just read it out. So when we have people coming to our website, just to give you some context, and they opt in for their free instant impact report or for their free video mini course, we ask them, what is your biggest frustration? And they can type in their biggest frustration, and that's where I get a lot of those videos from, the topics from, because it's basically what people write to us, what's their biggest frustration. So let's read out Diane's biggest frustrations. The doctors are just writing my husband off because of his previous stroke / bleed history, which was caused by a hospital anesthesia error, which due to lack of therapy has left him immobile, requiring 24-hour care. Although he is immobile, I feel that he is immobile due to lack of therapy as opposed to being immobile because his brain is not functioning properly. After 2 days in ICU, where they ventilated him on arrival because they said he wasn't breathing on his own, although prior to his ambulance ride when he vomited again, his pulse oximeter was between 89 to 92% of saturation. So I assume more vomit went into his lungs as he has pneumonia, which they are treating. They are recommending a tracheostomy before knowing if he will be able to breathe on his own once the pneumonia has cleared, before the blood from the bleed is absorbed, when they could fully access his body abilities to function properly. Wow, what a great question, and I really can break this down, you know, in some steps that, you know, you can understand. Um, so you know, I mentioned a minute ago that we're running an organization, Intensive Care at Home, and where we look after predominantly long-term ventilated clients with tracheostomy at home, right? And the reason I want to bring this up in this context is simply, you know, it sounds to me like your husband has been at home with a medical condition or with a disability. And because most of our clients at home are also in similar situations, the difference is that most of them are ventilated with a tracheostomy, or if they don't have a tracheostomy, they might be ventilated via BiPAP or CPAP. And if they don't have BiPAP or CPAP, they are often having a tracheostomy without being attached to a ventilator. In any case, all of our clients had to go or had to break through those perceived barriers from ICU, where ICU says, well, this person won't have any quality of life. Therefore, we should just write them off and stop treatment, because I believe this is what you are dealing with here, that the ICU team seems to be writing your husband off because he's had a stroke in the past, had a bleed, and he might have some long-term undesirable effects from that. That doesn't mean he doesn't have any quality of life. That doesn't mean he doesn't want to live. You know, that doesn't mean you don't want him to live. That doesn't mean he doesn't have a meaningful life. You know, meaning is in the eye of the beholder, not in the eye of the intensive care team. So also you are making reference in your email, Diane, that the previous stroke and the bleed history was caused by hospital anesthesia error. Now, I can't comment on that. I have not seen any medical records. You know, you haven't given us any details, but you are saying that this medical error left him immobile, requiring 24-hour care. Again, this is very similar to what we experience with our intensive care at home clients, when, you know, our clients rarely go back to hospital. If they do go back to hospital, you know, we have to go through the whole rigmarole again and advocating for them over and over again and saying, well, this person does have quality of life, right? And they want to live, and we keep them at home predictably with our intensive care at home nursing service. And just as a side note, with intensivecareathome.com, we are currently operating all over Australia, in all major capital cities, and including rural areas and regional areas in Australia. And we're also in the process of setting up intensive care at home in the US. We have now a clinical liaison nurse in the US, Tara, and I will record a podcast with her in the next few weeks so you can get to know Tara. Tara used to work for us here in Australia. She's a US citizen. She knows all about intensive care at home. But I don't want to get sidetracked here. I just thought I'll throw that in. So then, Diane, you're saying further in your email, although my husband is immobile, I feel that he's immobile due to lack of therapy, as opposed to being immobile because his brain isn't functioning properly. Look, it's often a two-way street. You know, it's almost like a chicken or egg question. You know, is it like in ICU when patients are in an induced coma, they get deconditioned very quickly. Once they're out of the induced coma and they can move again, how quickly can you mobilize them? You know, and you can do that whether the brain is functioning or not. It's often not a prerequisite to mobilize someone whether the brain is working or not. You know, in intensive care in particular, there are rehabilitation chairs that can be used. You know, it's hard work, don't get me wrong. It's hard work to mobilize someone, but it's definitely doable. Moving along, after 2 days in ICU, where they ventilated him on arrival because they said he wasn't breathing on his own, although prior to his ambulance ride, when he vomited again, his pulse oximeter was between 89 to 92%. So I assume more vomit went down into his lungs as he has pneumonia, which they're treating. Yeah, you're probably right on the money. They ventilated him because he probably had an aspiration pneumonia. And if they hadn't ventilated him, probably would have gone into a respiratory and then into a cardiac arrest, But the similarities here with our intensive care at home client is really, whenever they go into ICU, which is very, very rarely because we keep them at home predictably, we keep our clients home predictably because of the skills we're bringing in the community, right? We have to advocate for them over and over again. ICUs don't get it that these people, our clients, do have quality of life, right? So it's a constant process to keep advocating for what the clients want. And it's similar in your situation there, Diane, where they're recommending a tracheostomy before knowing if he will be able to breathe on his own once the pneumonia resolves. So here's a question that you might want to ask Diane. Because he had a stroke, can he swallow? Right? He must have been able to swallow because he didn't have a tracheostomy prior to this event. Now, you haven't talked about that there are any other neurological events adding onto this already complex situation. But what sometimes happens when patients have a stroke in intensive care, or they don't swallow, they can't swallow, they're at risk of aspiration. And that's when they need a tracheostomy, whether they need a ventilator or not. So just food for thought for you. The other thought that I have here, has your husband had any seizures because of the previous stroke? Again, that's a question for you. You may want to check in with. So you're also saying they're recommending a tracheostomy before knowing if he will be able to breathe on his own once the pneumonia resolves. Yes, absolutely. If he can swallow, they should be weaning him off the ventilator, full stop. Not talking about a tracheostomy. The goal should be to wean him off the ventilator, not let him decondition, because if he deconditions, again, it'll be so much more difficult to wean him off the ventilator. So get him up, get him out, get him off the sedatives, clear the pneumonia, try and work towards extubation as quickly as possible. And that's easier said than done sometimes. There could be setbacks. Your husband might be hemodynamically unstable. He might need antibiotics. He might need vasopressors. Could be all sorts of things going on. And then before the blood from the bleed is reabsorbed, when they could fully access his body's abilities to function properly. I'm not quite sure what you mean by that. You might be referring to the previous stroke. I can't be commenting on that. But the bottom line, Diane, here is this, do not let them ride off your husband. Maybe as a learning curve, when your husband is back home, maybe get an advanced care directive. By your husband having an advanced care directive and documented that he wants all life-sustaining measures to be performed if he's in a similar situation again. By that you have a legal document. But even so, you as the power of attorney, I assume you are the power of attorney, have the right to advocate for him and demand treatment. It's not optional. It's what it's what you want, and it's a legal requirement. So just keep advocating for him. So I hope that helps. And God forbid, if he does need a tracheostomy, again, that's when you should be thinking about intensive care at home and how to get him home with the right nursing care. If he does need a tracheostomy, God forbid, or a ventilator, whether it's non-invasive, whether it's invasive with a tracheostomy, whether he's not needing ventilation and he needs a tracheostomy, one way or another, you should be thinking about intensive care at home. And you can find out more information at intensivecareathome.com. That brings me back to Modema, our US liaison nurse. So Tara Thorpe is our US clinical liaison nurse. Tara used to work for us in Melbourne for 2.5 years. And she's a US citizen, and she was great working for us here. And then she went back to the US, and we missed Tara, and I think Tara missed us. So we started talking again, and we thought, well, what a great idea if Tara can help us to set up intensive care at home in the United States. Currently, what we are doing, full disclosure, Tara is helping our clients to find good service providers in the US that have the same quality approach than we do. So, we are in the early stages of talking to service providers that are interested in our clients, but what we want from the service providers is clearly the same quality approach than we do, right? And the same quality approach means that we are able to take patients home from intensive care. That can only safely happen with intensive care nurses 24 hours a day, right? We want that quality approach. If providers can't give that to us, we don't want them, quite frankly. If you're a provider watching this and you are interested in helping our clients to go home on a ventilator with a tracheostomy from ICU directly, and you are in the US, we want to talk to you. But we will screen you, and we will set high quality standards, just like we do here. We want high quality standards. We want intensive care nurses in the home, nothing less than that, right? And we also want an organization that has an understanding about funding, how insurances pay, so that we can create a win-win situation. So that's my take on it. If you are a provider watching this, please reach out to us either at info@intensivecarehome.com or call us on our US number on the top of our website at intensivecarehome.com. So let's move on to our next question. The next question came from Maria, and Maria says, my son has been in ICU following emergency bowel surgery 8 weeks ago. He had 2 failed attempts of coming off the ventilator, had a surgical tracheostomy now, had a smaller tracheostomy fitted, but still is struggling with mucus, which is hindering his ability to drink. Well, okay. Again, let me read this out again. My son has been in ICU following emergency bowel surgery 8 weeks ago. He had 2 failed attempts of coming off the ventilator. He had a surgical tracheostomy, now has a smaller tracheostomy fitted, but still is struggling with mucus, which is hindering his ability to drink. Now, I'm not clear on, whether your son is still on the ventilator. I would think that if they have a smaller tracheostomy fitted, I would think that he doesn't need the ventilator anymore. Otherwise, it would have, there would have been no point to downsize the tracheostomy from my experience. So let's assume your son is off the ventilator. Thank God for that. Now he's got a tracheostomy. Now he still has a lot of mucus, which in my mind means that he probably needs a lot of suctioning, right? And if he needs a lot of suctioning still, the question here is this: can he clear his airway by himself? Does he have a good strong cough, or does he still need suctioning? Right, that would be the most important question here, I believe. Right, that would be my most important question. Does he still need suctioning? Is he coughing? If he's at a point where he can almost cough out his tracheostomy, that would be a very good sign. Now, next question is, has he had a swallow and a speech test? Has he had a swallowing assessment? So your son seems to be off the ventilator, which is great. Again, otherwise they wouldn't have downsized the trach. Then the next question is, besides what I just explained around, does he need a lot of secretions? Is he coughing well? Can he clear his airway without suctioning? If he can swallow, great. Then the next step would be to cap the tracheostomy. What that means is put a cap on the tracheostomy, block the airway, so that they can see whether your son can breathe through the nose again. Right? If he can breathe through the nose, he can clear his airway, he can manage his airway, he can clear out secretions. He's obeying commands, he's with it ideally mobilizing. Swallowing test has been passed. no longer needs any secretions, any suctioning, they should be able to get rid of the tracheostomy. Okay, so that would be the next steps. I doubt that they would downsize him if he still needs the ventilator, right? I really doubt that. Okay, so I hope that helps. I think your son is getting there by the looks of things. So that is really, really positive. Let's move on to the next question. From Mel. Mel says, my mum was taken off sedation, and within 5 hours we were told she's essentially gone, no hope. Then she opened her eyes bilaterally and singularly. She was following my finger, our voices responding to family, and I almost caught her in the face and she flinched. She reacted to pain at least twice. However, she could barely keep her eyes open. She looked drugged. But after 12 hours of eyes opening, she began getting extremely tired and was struggling with the fluid in her throat. And I was told she was sedated again. I went to sleep in the hospital corridor, and 3 hours later, she was unconscious, exactly as she was before the sedation hold. But they're now telling us that she's not on sedatives, but they've repeatedly misinformed or misled us, and it really doesn't make sense to us and why they're doing this and what we should do. Okay, Mel, let's break this down, what I think is happening here, so to make sense out of the situation. And I can understand, what families are describing to me or to us. I've seen so many times where to me it makes sense, whereas to families it doesn't make sense. And that's what this show is for, to really make sense out of what's happening in situations like this. So let's go through the email again, sentence by sentence. My mother was taken off sedation, and within 5 hours we were told she's essentially gone, no hope. Right. Now, I presume your mum would have been on a ventilator, either with a breathing tube or with a trach, otherwise she wouldn't have been on sedation. Most patients in hospitals only or in ICU only need sedation and opiates once they're going on a ventilator to be intubated, and being hooked up to a mechanical ventilator, because it's so uncomfortable that patients can only tolerate that if they're going into an induced coma. And I know there's someone out there, Kylie Dayton, who disputes that too. Kylie has her own website, and she says, well, patients don't need to be sedated in intensive care on a ventilator. But I will probably record a podcast with Kylie in the next couple of weeks, and she can tell us more about her experience. So then Mel says, then my mum opened her eyes bilaterally and singularly. She was following my finger, our voices responding to family, and I almost caught her in the face, and she flinched. She reacted to pain at least twice. However, she could barely keep her eyes open. She looked drugged. Okay, so they're telling you your mum is dying, by taking her off sedation. Then you are saying that, she's opening eyes, and you think, what the hell? You think, what the heck is going on here? They're telling me she's dying, and then she's opening eyes, right? Again, what I don't know from this situation, but I'm just trying to piece together the puzzle, Mel, is was your mum on a ventilator or not? Is she on a ventilator? As part of them removing sedation, did they also remove the ventilator? Was this potentially positioned as a one-way extubation, basically where you were saying, they took off the ventilator, took off sedation, and they weren't going to re-intubate her, i.e. she was extubated to die. You haven't shared that, but maybe you simply didn't know what was happening. And this is why I'm sort of saying over and over again, the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. That's probably, again, a prime example for what is actually happening here with Mel's mum situation. So then you're saying she reacted to pain at least twice. However, she could barely keep her eyes open. She looked drugged. So here is another question. If it was a one-way extubation and she was meant to die, maybe they were giving her medicine again to put her back in sedation, this time without a ventilator, which could lead her to end of life because she might stop breathing, and that could be perceived as euthanasia, because giving her sedation when she's off a ventilator and opiates potentially, that's potentially hastening death. Let's get on. Because you were told she was sedated again. But again, I don't know, was she on a ventilator or not? If she was on a ventilator, okay, fair enough, then, it wasn't an end-of-life situation. So then you are saying, I went to sleep in the hospital corridor, and 3 hours later, she was unconscious exactly as she was before the sedation hold. They're now telling us that she's not on sedatives. Okay, she's not on sedatives. But they've repeatedly misinformed or misled us, and it really doesn't make sense to us why they're doing this and what we should do. Now, if patients in intensive care are on sedatives for a long time and you take them off and they wake up and then they go back to sleep again, there's nothing unusual there. Waking up after an induced coma is often not a linear process. It's not like switching on a light with a switch. It's like switching on a light with a dimmer, slowly and progressively. Okay. Also, if she has gone back to sleep, and she's not on a ventilator, she's definitely at risk of dying. She's at risk of aspiration. But if she's on a ventilator, then the next question is, how can she get off the ventilator? If she can't get off the ventilator, can she have a tracheostomy? Do you want a tracheostomy? Would your mum want a tracheostomy? Those are all questions you need to consider in a situation like that. Again, it's not straightforward. It's not as simple as someone is dying in intensive care. It also comes back to, is this a real or a perceived end-of-life situation? What do I mean by that? A real end-of-life situation in intensive care is, no treatment, no surgery, no nothing can save someone's life. A perceived end-of-life situation is, can a life be saved? If we stop treatment, will someone die? If we continue treatment, can someone live? Right? Again, that's why I'm saying, does she need a tracheostomy? If she doesn't need a tracheostomy, does she want to live? What if she can't get off the ventilator? What if she can't get off the tracheostomy? What are the implications of that? Again, that's where services like intensive care at home might come in. You can see it's a puzzle, and death is often not the only option, or death in a hospital is often not the only option. For example, with intensivecarehome.com, we're also providing palliative care and end-of-life care at home. Okay, so Madema, you've made a comment. You're saying, I suspect she was on a ventilator. They just backed off sedation to check her responses. Just guessing. Yeah, you're probably right. You are probably right. I suspect the same. It's just not clear from the email. That's all. So, there are, it's not a one-size-fits-all, those situations. Intensive care units try to present it as a one-size-fits-all, but it's not a one-size-fits-all. Intensive care is not black and white. It's not, you're going to live, you're going to die. If you are going to live, what does that look like? What are your options? How can you live? What's your quality of life like? What support services do you need? What are the options? You got to dig down really deep, and don't let ICU teams get away with just one opinion and saying, well, your loved one is going to die. Well, get the facts. Get the facts. How can you get the facts? You can get the facts two ways. You can get the facts by, purchasing some one-to-one consulting with myself, and then we can talk to the doctors directly, or we can look at medical records. Ideally, we do a combination of both to really get to the bottom of things, because what's missing here, Mel, is, you don't have a good understanding of what's exactly happening. And that's when we come in to help you break it all down, make sense out of it, and give you options so you can make an informed decision. That's what it comes down to. Okay, let's move on to the next question, and yes, you're right, Modema, it's so overwhelming for families. I can probably read the situation just by looking at an email with insufficient information, but that only comes after decades of experience, where I can piece the puzzle together just by reading an email. Here is another email from, it's an email from email subscriber Just Me. She says, after 2 weeks, they gave my son a tracheostomy and kept him on all those medications they offered. ICU at home, but never made, ICU at home would have been an option, but never made arrangements to move him. He never woke up. He died in that state on the 9th of January 2023. What a shame. Again, it's a small snapshot of information that only presents 2% of the information I would need to know in order to make sense out of it. Yes, tracheostomy, if someone is hemodynamically stable, they're not on pressors or inotropes, intensive care at home would have absolutely been an option. Many families forget that, a medical record review should happen in this situation. Other options you have in a situation like that, you could ask for an autopsy, right? Or, you may need to find out even whether that's a coroner's case. I don't know the ins and outs, but, if you want answers, ask for it. And with intensive care at home, you need to contact us as quickly as possible so we can channel your efforts, care, and treatment in the right directions as quickly as possible. Okay, so let's move along. Next question. From Brenda. Brenda says, I need help with my fiance passing in ICU. He had finished treatment for esophageal cancer, radiation, and chemotherapy. He had a tracheostomy put in because his vocal cords were paralyzed, and he had difficulty with breathing. 4 days after the tracheostomy surgery and still on the ventilator, he got sepsis while in ICU. The doctors say it came from infection in his lungs. Antibiotics were not working. The doctors say he was getting more and more bacteria in his system. My fiance was in multiple organ failure. Doctor says, and then she finishes without completing the sentence. Anyway, I think there's enough in there to shed some light on you, on this situation, Brenda. I'm so sorry to hear that your fiance died in ICU. Now, he might have gotten an infection, because he was ventilated. A lot of patients in ICU end up with a ventilator-associated pneumonia, also known as VAP. The next thing is his vocal cords were potentially paralyzed because of the radiotherapy, chemotherapy he had around the neck because of the esophageal cancer. Not sure about that, but that could be the reason why. When someone is having chemotherapy or radiotherapy, their immune system is getting so weakened that an infection is almost predictable, because the immune system is so weakened. Bear in mind, if a patient is in ICU, they're also exposed to many bacteria, viruses, because there's so many sick people in the ICU, and the doctors and nurses might carry those bacteria and viruses from other patients, to your fiance, for example. So, and therefore antibiotics may not have worked because his immune system was so weak. Hard to say, but I've certainly seen that sort of thing. So, and you are also saying my fiance was in multiple organ failure. His lungs would have failed. Maybe his immune system failed. Maybe his liver failed. Maybe his kidneys failed. Maybe his heart failed with the infection. Maybe he needed vasopressors and so forth. We don't know, but we can only, again, try and piece the puzzle together here. Whatever you're saying, I wonder how long he was on the ventilator before the trach. Yeah, we don't know. We really don't know. it's hard, it's incomplete information. But what I would recommend for Brenda is, to contact us, and we can review the medical records of your fiance. That would help you in getting some closure. I hope that helps in terms of shedding some light on what might have happened here. Again, with radiation and chemotherapy, very likely that your fiance would have gotten an infection because his immune system is so weak and he's been exposed to too many hospital bugs. This is why, again, I believe intensive care at home is the best option. Now, if your husband your fiance was in multiple organ failure, intensive care at home may not have been an option. But again, we would need to look at the medical records to understand the full picture. Modema, you're saying it's a fairly common secondary infection in the ICU. Yeah, absolutely. Ventilator-associated pneumonia. Unfortunately, it's a very common theme. Now, before I get on to the next question, if you do have any questions, you can type them into the chat pad. I'll just type in the numbers. If you want to dial in live on the show, you can do so now. If you are in the US, you can dial in on if you are in the US, in North America, you can dial in on 415-915-0090. I'm just typing those numbers into the chat pad. If you are in Australia, you can dial in on 041-094-2230. And if you are in the UK, you can dial in 0118-324-3018. I'm just typing those numbers in. I welcome you to dial in, and I can answer your questions live on the show. Or you can just type them into the chat. But in the meantime, while I'm waiting for your questions, I'll have another question to go to that we had via email. This is an email from Amal. Amal says, I would like to be advised. My husband had a cardiac arrest on February the 20th, 2023, with hypoxic brain injury, damage. MRI has been done. He was in a coma for 5 days in the ICU, then came off deep sedation. He opens his eyes at day 6. Currently, he's moving his shoulders and tilting his head. He's opening his eyes with pain stimuli. He's also trying to move his lips. Today, he's trying to move his hands, both sides. The doctor reduced his anti-seizure medication to half of the dose. From your experience, what do you think about his prognosis? Well, if he's waking up after day 5 after cardiac arrest and with hypoxic brain injury, I do believe that's a good sign. Now, very important not to get impatient here and not lose sight and take one step at the time. He needs to get out of the induced coma. He needs to stop having seizures. He needs to get mobilized. He needs to be weaned off the ventilator. If he can't be weaned off the ventilator, does he need a tracheostomy? Question also is with the cardiac arrest, does he need to go to catheter lab for an angiogram? Has he had an angiogram already? Does he need to be stented? Does he need open heart surgery? Those are all questions that you need to consider. But it's a good sign that he's waking up after 5 days. And sometimes you have patients not waking up without a hypoxic brain injury, and you just got to be patient. You will need to push for physical therapy, get some cardiology input, because you also don't want this to happen again. What's the cardiologist saying about all of this? What's the neurologist saying about all of this? What's his prognosis from a neurology point of view? It's one thing to have an MRI scan that says certain things, but what's his actual prognosis? Talk to the neurologist. So I think overall these are good signs. Make sure he's now getting physical therapy, breathing exercises. People talk to him, talk to him about the future, talk to him about maybe the past as well. Talk to him about your family. Make sure he's got familiar faces, familiar voices around him. Talk about what's important to him. That would be really good, and go from there. But do not give up. It sounds to me like your husband might be on the right track here, and that is certainly a good sign. Now, that's what I have to say in regards to this. I do want to slowly wrap this up. If you do have any questions, please type them into the chat pad now, or type in or dial in live on the show on one of the numbers that I put in the chat pad here. If there are no other questions, I'm going to wrap this up for today. I'll be back again next week at the same time, 10:30 a.m. Sydney, Melbourne time. I don't know next week's topic yet. I have to think about it. 10:30 next week a.m. Sunday, the 9th of April, 10:30 a.m. Sydney, Melbourne time, which is 8:30 p.m. Eastern Standard Time, 5:30 p.m. Pacific time. And then you can dial in live on the show there again, ask your questions there. I will also publish some quick tip videos during the week. Keep an eye on them. And thank you so much for watching. Thanks for coming onto the show. You can also dial any questions, even if you're watching the recording, and then I will make a video about it. Thank you so much for watching. Now, if you have a loved one in intensive care, go to intensivecarehotline.com, call us on one of the numbers on the top of our website, or simply send us an email to support@intensivecarehotline.com. I'll also offer one-to-one consulting and advocacy with me directly. Also have a look at our membership for families in intensive care at intensivecaresupport.org, where you have access to me and my team 24 hours a day, and we answer all questions intensive care and intensive care at home related. Also, if you need a medical record review, contact us as well. We help with medical record reviews in real time in ICU, but also after ICU, especially if you need closure, need peace of mind, and especially if you suspecting negligence, we can help you find out whether there's been negligence or not. Now, also, if you have a loved one in intensive care and you want to go home because your loved one has ventilation, tracheostomy needs, home TPN, non-invasive ventilation such as BiPAP or CPAP, and is stuck in ICU or on a respiratory ward, respiratory floor, we can help you with home care at intensivecarehome.com. Check us out or email us to info@intensivecarehome.com or call us on one of the numbers on the top of our website at intensivecarehome.com. Thank you so much for watching. Subscribe to my YouTube channel for regular updates for families in intensive care. Click the like button, click the notification bell, share the video with your friends and families, and comment below what you want to see next, what questions and insights you have, whether you agree or disagree with my answers. I want to know all about it. Thank you so much for watching, and I'll see you again next time. This is Patrick Hutzel from intensivecarehotline.com and intensivecarehome.com, and I'll talk to you in a few days. Take care for now.